Well, as a sign that we're approaching the beginning of what hopefully will be reactivation and a resumption of some semblance of normalcy, I'm glad to welcome everybody to our first post-COVID surge crisis grand rounds. We've had town hall meetings weekly or more, and then we had the annual meeting last week. And for July, we have scheduled some really interesting presentations, all related to COVID in one way or another by faculty. I'll be introducing our speaker today, but next week we will have a faculty member from the Department of Pathology, Eldad Hod, who actually on March 1st began from scratch to devise the RT-PCR and serologic testing for COVID virus and antibodies to tell that story. After that, Catherine Shear will be speaking on grief and one of the cardinal emotional disturbances that people are feeling during the crisis, as well as trauma and anger. And then finally, Jonathan Torres from Harvard will be here to talk about digital technology and how this is likely to play a big role in the post-COVID environment for healthcare. But today, it's really a pleasure and an honor to introduce. He received his bachelor's degree in psychology at Hofstra and a medical degree from the University of Miami. And he received a Doctor of Science degree from CUNY at Hunter College. He then undertook training in pediatrics, initially doing his internship at Columbia and Babies Hospital, then at the University of Colorado's vaunted Denver Children's Hospital. And then he came back to New York and Albert Einstein for a fellowship in neonatology. And it was shortly after that that I first became acquainted with him, really just by word. And I have to admit, somewhat sheepishly, I was kind of a groupie because I didn't know this guy, but I read about what he was doing and I said, wow, that is really cool. This guy's a out-of-the-box thinker. And it's because he clearly was committed to pediatrics, but on a community or population basis. And healthcare wasn't really addressing it in an adequate way. It still isn't, for that matter. But it didn't stop Dr. Redlener. He evolved a strategy by which he could do so. And he did it in the context of his post-training positions, which were at various institutions in the city, including Cornell, including Albert Einstein and Montefiore, and finally in Columbia. But it was at Einstein, or beginning at Cornell and at Einstein, that he developed this children's initiative to provide care to underserved populations or underserved communities, and also in the wake of traumatic experiences, which could be considered social adversity or genuine crises of one form or another. So before trauma was really on the radar screen, trauma-informed care was on the radar screen, Dr. Redlener was doing it, and he did it in a very unique way. He got funding philanthropically from individuals, including the singer Paul Simon, and developed mobile vans that would go around to the community and provide various types of care to people. And this was quite extraordinary and continues to this day, although he's not actually driving the bus at this point. But while he was at Einstein and Montefiore, he rose to the level of vice president and then president of the Children's Hospital at Montefiore. But then in 2003, he came to Columbia, where he was or is the director of the National Center for Disaster Preparedness, the director of the program on child well-being and resilience at the Earth Institute, and professor of health and policy and management at the Mailman School of Public Health, and professor of pediatrics in the College of Physicians and Surgeons. In addition to his academic activities, he's been advisory to government officials at the all levels, federal, state, municipal level, and is now being called upon in the COVID crisis as a frequent commentator in the news media. So I'm glad that we could get him here to share his views on what we're going through with us. So I'm not going to ask you to welcome me. because we can't hear the applause. But Irwin, I'm glad that you could be with us today, and we're going to have you come back in various capacities in the future.
Great. Well, thanks very much, Jeff, and I look forward to talking to all of you. But there's a caveat I just wanted to say beforehand, is that we're still obviously in the middle of a massive crisis related to the pandemic. And there's a long list of things that we don't know about where this is going, and even the behavior of the virus itself. But let me get into this. I'm going to attempt Simon's help to share my screen here. And I think we're ready to go. Okay. So let me get into this. I'm going to keep this relatively brief because I do want to get to the questions and answers, and I guess it'll be mostly questions because we don't have that many answers, but we'll try to do the best we can here. By the way, just today I stepped down as director of the National Center for Disaster Preparedness, and I'm still very deeply involved with the Earth Institute at Columbia and Emeritus of Children's Health Fund, as Jeff said. So, all right. So why am I not advancing this? Okay, whoop, let me go back here. Sorry. And I'm sure you've been following this in the paper, but the United States is in a real serious crisis right now, because as opposed to seeing, like is being seen across Europe, a serious dip from the peak that was happening in April and early May, we have actually seen a very serious resurgence, the likes of which we had not anticipated a month ago. And this has really put us in a very difficult position. There are many factors that go into why the United States, say compared to the European Union, is in an entirely different reality here. And I see is my picture blocking the end of these curves, or can people see it?
We can see it clearly.
Okay, great. So we have a lot of splaining to do, as they say, because we should have been where the European Union is. And, part of his politics and mismanagement from the top, which I'm going to go into a little later, but a lot of it has to do with very significant uncertainty about what people should be doing. And I'm going to talk a bit about that as well, because the messaging issues are very germane to what we're seeing here. And the consistency among various states and localities in the policies related to controlling the coronavirus are random. They're random acts of response to COVID, and that has created a potpourri of strategies that have not really worked very well overall as far as the country is concerned. So U.S. cases are surging, as we just saw. The Sun Belt in the South, as opposed to the original surges and incredible epicenter status globally that New York had just a couple of months ago, now shifted to the Sun Belt in the South, with huge outbreaks in Texas, in the Carolinas, in Arizona, Florida, and so on. And that is something that we need to be paying attention to. And also, the average age for people testing positive has become much younger than it had been. It's somewhere between 30 and 40 as we speak, and it had been, in the 50, 60 and older range not very long ago. And a lot of that has to do with a variety of factors where younger people are feeling pretty invincible, which has always been the case. I'm sure I've had my share of feeling invincible and immortal when I was younger as well. But this has now become a public health problem that is not something that we've really experienced very much before. Increasing hospitalizations are part of this. It's not just testing. I'm going to say that a couple of times. And, the president and the vice president and others have been saying that, well, the increase that we're seeing is just a matter of we're doing more testing. Well, first of all, we're not doing that much testing. And second of all, it certainly does not account for the increased hospitalizations that we're seeing everywhere. The inconsistent federal policies or the dishonest federal policies, depending on how you'd like to articulate that, has caused from the very beginning of this random acts of response, say among the states and cities, where Seattle early on, when they first started instituting policies that were designed to control the spread, they were saying things like, we're not going to allow people gathering in crowds of more than 250 people. And then New York City said 100, and some other places were saying 10. All of this happening in a vacuum of overarching national policies, so that cities and states were basically going on their own. And this is one of the problems that we're seeing manifest right now. The messaging issues, the reopening, which began on April 24th with Georgia beginning phase one of its quote unquote reopening, that the reestablishment and reopening of businesses and allowing people out of the sheltering in place situations they had been in. Even though it was phased, and even though there were caveats in most places, many people heard reopening, but what they thought they were hearing was we're going back to normal. And that misinterpretation of reality has been a major problem that's been very hard to put back in the bottle, especially when the words and the optics of the President of the United States reflected an entirely different situation, like are back to normal. And I'm going to get into the politics at the end of my remarks, but I think it's really important and germane to what's going on. But this point that I'm just mentioning again is that certainly the surge that we're seeing right now has nothing to do with more testing. Tony Fauci, I guess the day before yesterday, said that we could be reaching 100,000 cases per day. We're now in the thousands, and that I don't think that's in any way out of the question. So I think we will be seeing vast increases in the number of cases, and we're still vastly unprepared when it comes to testing and case management and all of that. So there are some things that we do know about this virus. It's a new virus, a novel virus. It's everywhere, which makes it a pandemic everywhere in terms of everywhere on the planet. It's highly infectious. There's a key point here if you haven't heard this before. So people can catch a very dangerous new virus from an animal, and that could be a serious problem in many places. But the inflection point where it becomes a pandemic is that it's, first of all, ubiquitous from an international point of view. It is infectious and can be lethal, but that can be transmitted not just from an animal to a human, but from human to human. And once you have conditions in place, like was clear in March, we can declare it a pandemic. Probably started in China. There's still minimal questions about it, but I think it started in China. Multiple waves are likely. What we're seeing in the Southwest and the Sun Belt is not a second wave. It's still part of the first wave. A true second wave will likely happen in fall and in the winter. And that, unfortunately, will be coincident with the onset of the influenza season, which typically can kill between 20,000 and 55,000 people per year, and will also have the possibility of overwhelming the hospital system. So we have a second wave coincident with a new influenza, and we're just looking for trouble, and I'm very worried about all of that, and we'll see what happens. But we're talking about things like opening schools, and we will, but I'm not so sure how long that will last. Cases and fatalities continue to rise, and we'll start seeing more and more outbreaks in unexpected places, including rural areas, where even though they don't have the population density, there's lots of. I spoke yesterday with President Jonathan Nez, who's president of the Navajo Nation, which, by the way, it's a huge landmass across several states. And the Navajo Nation's just geographically, size-wise, is larger than 10 of the other U.S. states. It's a vast area, and they are having cases. Their hospitals are overwhelmed. He was talking about the need for things like disinfectant spray and wipes and all that, because there's only, in this vast area, there's only 11 supermarkets. And so they're stressed and stretched. They have PPE because Bravo Nation challenges have gotten a fair amount of attention from Sean Penn and the like, but right now they need certain things which we're going to try to help them with. What we don't know is this is really just a sample of some of the things that we're working on. We don't really know the infectivity rate. There are things like super spreaders who for some reason are able to infect a lot more people if they're positive, if they're carrying the virus. We don't know exactly what the mechanism or why that is. We don't really have medications that are specific yet. There's hundreds and hundreds being worked on, but right now it's safe to say we do not have an effective medication. We have things like remdesivir, which is probably useful for people who are very sick in the hospital, and mostly we know that it shortens the hospital stay from 15 days average to 11, and it has some effect on lowering fatality just a little. But it's not available. Like, for example, if you just have sick and symptoms and you want to take something to get better and not get very sick, that doesn't exist yet, at least not available. The issue of vaccines, of course, the vaccine development, when and if it's successful, will be really the key to stopping the spread of COVID, but we're still far away from it. The most optimistic virologists and vaccine manufacturers and academics working on this think that maybe in the first quarter of 2021, we'll start, if we're lucky, having something that could be widely available and distributed and so on and manufactured in quantities. Don't forget, we're going to need 7 billion doses for the world, and that's not a minimal manufacturing issue. There is a question of if we'll get a vaccine because if the virus mutates, or if we find out that the vaccine has some any vaccine has some untoward reactions, it'll be devastating in terms of our plans to really get control here. We don't exactly know why some countries were hit harder to begin with. That's still being looked at. If you have COVID-19 once, can you get it again? Maybe, maybe not. Some big studies, including at Columbia and Mount Sinai, the one at Mount Sinai has tested 20 or 25,000 people, and those who have antibodies to COVID-19 so far, nobody has had a recurrence of the disease. How long immunity lasts? A month, 2 months, a year, no one knows. And we also don't know the full medical impact picture of COVID-19 because, there are people with long-term neuropsychiatric symptoms, GI consequences, thromboembolic issues, which is why many people now are being treated presumptively with anticoagulants and so on. This is a very, very complex medical thing. It's not just a question of landing in the lungs and causing acute respiratory distress. Should we have started reopening business on April 24th? Decidedly not. We did a report on the 27th saying that in order to safely reopen businesses, we need point of care testing. We need appropriate, rigorous contact tracing and strict protocols. We have none of this. By the way, point of care testing means my hair was like this, was very, very long, and I wouldn't, go to the barber unless I knew that he was actually safe from a virus transmission point of view, and I arranged for him to go to Mount Sinai, where my daughter-in-law is involved in the antibody plasma antibody program, and we got him and his brother, the other barber, his father, and his wife tested, and they had been sick, and they all had high levels of antibodies. So I went and got a haircut. But if you don't know that your barber or your nail salon or if you go to a restaurant, if you don't know that the kitchen staff and the servers are negative that day, then you're taking a chance. And we're in this very precarious situation where separating the tables and masks has no assurance that you're not going to get sick. So if we had point of care testing, didn't have to go to a lab, we could know that information immediately. Contact tracing, about 6 weeks ago, we had something like 2,000 people in the country trained to do contact tracing, meaning tracking down people who have been in touch with those who were positive. And it was estimated we needed 100,000 trained contact tracers, and it's happening very slowly, but we're still not where we should be. And then strict protocols of masks and separation and so on. Mental health impacts, I'm really not going to say anything about this to you all. You probably know all of this, but all kinds of issues that have affected people that, around, and not just obviously having the disease, but the stress of the changes that we've had to go through. And by the way, I just want to say one word about this, is that this is very difficult for everybody, all of us, my own family included, and the isolation and having to have meetings like we are right now online. All this stuff has had a very weird impact on people in a variety of ways. But just to remind people, and it's worth hearing, you think about the Great Depression, how long that lasted, World War II, the Dust Bowl in the 30s. We've had times in our history where there's been enormous societal stress that has translated down to individuals. And I think we're just going to have to get used to or figure out strategies for coping, because I don't think this situation is going away anytime before late 2021, if we're lucky. A couple words about children and COVID-19. First of all, there have been very few fatalities of kids from the acute disease early on. There were 3 deaths reported out of China, a toddler and 2 early young teenagers, and all of them had pre-existing conditions. But we do know that children can be asymptomatic carriers, and a lot of them probably are. And then we had an outbreak of what is called multisystem inflammatory syndrome in children, MISC, which is a terrible post-acute illness situation from an overreactive immune response, a delayed overreactive immune response that's been it's still very, very rare, but very frightening. People have read about it. Kids are very resilient and adaptable, but for how long, I don't know, especially if they're increasingly stressed. There's all kinds of long-term possible repercussions in kids. And one of them, this last one I just put up, is that people may not have thought about this, but children have not been able to go to the regular sources of care. And many children, especially those living in poverty, are behind in their care, and they have many of them are way behind in their immunization schedule, and that has to be dealt with. And a secondary complication, of course, is food insecurity. And I'm not going to dwell on this either, but if you look at this graph, and I think you'll all have copies of the whole presentation, but the food insecurity, hunger, not getting enough to eat, has risen very sharply among families and children throughout the United States. There's been many, many studies, and this is just one that from a Gallup survey that asked parents how their kids were doing and what they expected over the next few months. And you could see that many, many parents are worried about the mental health impact for kids. We're not going to talk much about the global issues, except that the disruption in education, which we're seeing in the US, affects the entire world. Their estimates are up to 70% or more of the world's 1.5 billion students have been impacted by school closures because of lack of access to care, more deaths from the common diseases we find among globally underserved populations, et cetera. So the one point I just want to make about this and what's happening in the US, that the disparities, who gets the worst impact, which have to do with racial disparities and income disparities, are very significant. And these are the children that we're extremely worried about. Karen Redlener and I wrote an op-ed in the Washington Post in May about something called the pandemic generation, and what's going to happen to all these already vulnerable children as we go forward. So we need everything: more meds, more tests, vaccines, contact tracing, the stuff that we've just mentioned. In the op-ed that we wrote, we called for a Marshall Plan that focused on vulnerable children to guarantee that every child had access to quality health care, mental health services, and whatever it is that we need to do to help them catch up educationally. Children reading at 8 years old or reading below grade level have a great deal of difficulty in the 8th grade and graduate less frequently and less frequently on time. So the consequences of missing school for vulnerable children are lifelong. And if you want to talk about that later, we can. So what now? All of these things, but I just want to kind of get to the conclusion of this. But let me stop with this last bullet. Should we reopen schools in the fall of 2020? New York City will be, unless something drastically changes in the next month or so, and we'll probably hear about this in a few weeks, but schools will reopen in New York City. We're talking about 1,000 schools, 1.1 million children in the public health system, and in the public education system. They need to get back to school, but there are many, many caveats, and many researchers think that that's a dangerous idea. But we'll see. There's going to be going back to school, but probably split classes or some arrangements where we're not crowding kids in school, and something to help make sure that we don't cause problems in teachers and staff that may be older and at significant risk. Big open question. So, so I want to conclude this by saying a couple of things that are kind of big picture and political. So first of all, we've never had a coalescence of issues that we're having right now. So we have the pandemic. We also have a long overdue revolution for social justice and the ending of disparities, the ending of racism that are overlapping. And then we also have the natural disasters. We're into hurricane season and we're into wildfire season. So President Nez, the president of the Navajo Nation, I told you I was speaking to yesterday, they're experiencing massive wildfires on top of the social disruptions, but especially on top of an ongoing COVID problem. And this is, to say the least, highly challenging. So I want to end with this, the political influences on our ability to deal with COVID. And so this is the famous MAGA hat, which has been the symbol of support for Donald Trump and his policies. And here's the president in Tulsa a week and a half ago with the rally. See if you can find somebody wearing a mask. Oh, I can't either. Yeah, so this message that is totally counter to good public health practice is emphasized and re-emphasized by a recalcitrant, ignorant person in the White House. I don't mean to be so blunt, but I mean, what can you say? And what's one of the strange things about this is that you don't actually need a MAGA hat anymore for people to know who you stand for. These are some unmasked Trump supporters yelling at a reporter who's wearing a face mask. And so in some ways, the defiance about not wearing face masks has replaced the MAGA hat in terms of helping us understand where people are coming from politically or ideologically. How strange it is. And this I wrote about in an op-ed in the Daily Beast a couple of days ago, but President was impeached by the House in December for 2 articles, abuse of power and obstruction of Congress. And these were serious charges, but as obviously we know, the Senate did not convict on those things. But instead of those articles of impeachment, I propose in this op-ed articles of incompetence, ignorance, and dishonesty a couple of days ago in something called the Daily Beast. And in case you can't read this, Article 1 is dismantling a working group that Obama had established to deal with future epidemic or pandemic threats. Article 2, inexplicable failure to create reliable widespread testing. 3, deliberate deception of the American people by reassuring them that the pandemic was under control, certainly done with by Easter when warm weather started happening, which would result in a miraculous disappearance of the outbreak. 4, practicing medicine without a license by this crazy promotion of hydroxychloroquine from his powerful bully pulpit, and this even crazier public musing about possibility of injecting bleach and other products or insertion of ultraviolet light in the human body. 5, lying to the American people about the fact that it was safe to open U.S. businesses, et cetera. In Article 6, the unconscionable politicization of this public crisis, which I think is all about a re-election campaign. I'm sorry to end on such a grossly partisan political point, but we can't really ignore this. And it seems like making a phone call to the president of Ukraine to try to get him to influence the 2020 election was important, but compared to these crimes or however you want to characterize them, is sort of a big nothing burger to me. But anyway, this is where we are, and let me leave it at that and turn it back over to Jeff and all of you. So thank you.
Irwin, thanks for that review of what we know and what we don't know. And unfortunately, it's probably more of the latter. We try and steer clear of politics usually, but I can't help but follow up on your last comments by saying, no shortage of issues which one can impeach or question president competence or honesty or whether he's living up to his oath. But the mechanism to deal with it really was the 25th Amendment, but that
Right.
had no chance of being invoked because of the fact that our vaunted separation of powers, which is supposed to be a safeguard against one branch of government assuming too much authority inappropriately, has failed. Congress has been co-opted, and even the Supreme Court has been politicized. So I think the big lesson here, apart from the fact that infectious diseases are not a thing of the past, despite antibiotics and vaccines, is that governmental systems are highly fallible, and we're experiencing that ourselves right now.
We are, and it's hard to know what to do about it. And an academic setting is not usually the place for political discussions, but it's impossible to extricate the politics of this managing this disease from what we're actually experiencing. And I think it would be just derelict not to kind of bring it up. But anyway, I think it's very complex. And even if we didn't have the political issues, we certainly do have so many unknowns, Jeff, as you're saying, about this disease and many of the behaviors of the virus itself. So the fact is that, it's a very complicated time right now, and especially with the concurrent issues of other natural disasters and this massive, as I said, long overdue, hopefully successful attempt to deal with institutional racism finally and definitively.
So what we're going to do is Jonathan and I are going to engage Dr. Redlener in a brief discussion for 15 minutes, and then we're going to take questions that are being sent in now from people who are attending. So Jonathan, do you want to chime in?
Yeah. Thanks so much for that talk. That was really, really terrific. I guess I had sort of a comment and a question. So you mentioned in your talk, and then also in your Washington Post piece, the incredible secondary impacts that this is having on children, and the need for something like a Marshall Plan to address that. And I guess my comment is I very much like that idea, in part because it's somewhat of an aside, but George Marshall never actually wanted that plan to be called the Marshall Plan. He wanted funds to help rebuild Europe, but he was oriented towards public service and not self-promotion, which I think is sort of sadly missing in today's politics. But my question was, you touched upon it a bit in your talk, but I was wondering if you could elaborate on what would you see as the priorities for that type of program?
Well, to me, and it's not just because I'm a pediatrician or a grandfather of 7, but I think the big macro issue here is that if we don't, first of all, recognize the issues that children will be facing going forward and the consequences, even if we're done with this in a year and a half, there are children who have lost so much, and it's mostly the highly vulnerable kids that have lost their educational trajectory and access to healthcare, et cetera. So we're creating a hyper vulnerable generation of children. And that is something that is deeply distressing, because if we have children who are growing up in poverty, who have not succeeded academically, whose life opportunities will be drastically reduced because of that, they'll end up, raising another generation of kids in poverty. And it's terrifying how this will just keep recurring and exacerbating over the generations. And I think we need to stop that in its tracks. Adults suffer. There's plenty of people, older people, who medically or psychologically or sociologically are struggling. There's no question about it. But, we will get through this. Like I said, we've had other long-term traumas in our society that we just get through. But for children, they don't just get through. They suffer consequences that may be irreversible. And if we have a generation of children that ends up, who have experienced this and end up undereducated and therefore don't have opportunities, that's a price we'll be paying for decades. And that's why the focus on children. And the pieces of this would be trying to make sure that every single child, and this actually works as the plan for how we're going to try to deal with the institutional racism and 400 years of slavery, Jim Crow, and institutional racism. The same thing really for this pandemic generation. We need to be able to commit enough resources so that every single child, especially vulnerable children, are getting government support to make sure that they're getting a quality education and a makeup education going forward, that they have access to quality health care, and that we've supported families enough to get them out of poverty. And those are the building blocks of what I see as what might be in a quote unquote Marshall Plan, or whatever it's going to be called. But I think it needs to be named something, because we want a lot of focus on this, and we want metrics so we can see that we are in fact making progress and that we are devoting enough money to make this happen. And we have the money. We're not like many countries that are in terrible straits economically. U.S. has the money, and we have to figure out a way to pay for it. But I think that's the next step.
Irwin, we're in a mess, and as you said, it's going to continue for a long time. But the Deus ex machina, if there is one, is the vaccine. But if we do get a vaccine, whenever we get a vaccine, is it going to be like an influenza seasonal vaccine, or is it going to be like a smallpox polio vaccine?
Right. Probably the former, but no one knows. And by the way, I just want to say that it's possible that we won't get a vaccine. I mean, we don't have a vaccine for HIV. We don't have a vaccine for hepatitis C, even though people have been working on it. The fastest we've ever developed a vaccine was for mumps, and that took 4 years. There's new technologies and new approaches, and we have hundreds of companies working on developing a vaccine. And there's certain parts of that early research that can be accelerated and supported through money. But what we can't really accelerate, I've been speaking to a lot of virologists and vaccine experts about this, is that the limiting factor to very rapid development factors, let's say, the first thing is that we have to have enough vaccine given to in the human trials phases to make sure that we have a vaccine that actually is effective in preventing the disease from manifesting. And more importantly, we have to know that the vaccine is safe. That means that you have to wait some period of time after you've given vaccine to volunteers to make sure that we're not developing, like happened with swine flu, like increased cases of Guillain-Barré syndrome and so on. So there's a lot of waiting time that's built into the system, no matter what the vaccine. And some of the vaccines that are in development are based on entirely new RNA technologies, and there's still a lot to be learned. They may not work at all. We have no idea. So what we don't want to do is delude ourselves in false hope that something will happen rapidly. And again, we don't know how long the vaccine will, if we do have a successful one, will confer immunity. But the other thing, Jeff, is really important is, will people take the vaccine? We already have a very powerful anti-vax movement that started in the US and is global. There will be widespread resistance to taking the vaccine. And if we don't hit whatever the magic threshold of vaccinations might be to incur herd immunity, we're going to be in trouble with this for a very long time. But can't you just see the headlines of and the social media explosion of people saying, don't get this vaccine, it can kill you, it can cause this or that or whatever it might be. So I think the challenge of even getting enough people vaccinated to give us herd immunity is going to be enormous. If we start having side effects, it's going to just exacerbate that problem. So will we have a successful vaccine? Maybe. Will we give it enough time to make sure it's safe? Maybe. Will we have such an uproar from the people opposed to it on principle and ideology? On and on. So I wouldn't get my hopes up for the vaccine being able to solve our problems in the next, foreseeable future.
Unmute yourself, Jonathan.
Thank you. Sorry about that. Yeah, another question I wanted to ask is what if you could talk a little bit about what role you would foresee or hope for psychiatrists and mental health providers to help mitigate the negative effects of the pandemic on children and families?
So, yeah, this is an extremely important question because at the end of the day, whatever's happening medically, we're not going to be able to just instantly eradicate the psychiatric and psychological complications from this. I think Jeff was telling me the other day that there are people with certain kinds of serious mental illness who actually are not all that affected, but many people are, including lots and lots of people who have before had anything approaching mental health or psychological problems that needed professional intervention. But I think the entire profession, from social workers to psychiatry and in fact, family practitioners are going to need to learn a lot about strategies to help people cope. And I think for psychiatry and the professions that formally do deal with mental health issues are going to need to be able to provide guidance for people in general, for the population in general, and for non-mental health oriented health professionals. Like I said, family docs and others, internists, everybody, going to have to be informed by your profession about steps to take. How do you recognize when somebody actually needs more advanced care and support? And a lot of people, something I want to say, there are a lot of resilient people. Let's not forget there are a lot of people that are handling this just fine, especially people of, appropriate means that they can, that they don't have to worry about overcrowded, non-air conditioned apartments in the summer, that the wealthy who have places, out of the city that they can retreat to in the country and so on. But I would say this about resiliency from our experience with other disasters. Resilience is a very dynamic reality. So you may be resilient to whatever it is for weeks, months, or more, but at some point we have a waning of resilience over time. And so that if things aren't made better, if people don't see hope for the future, that somebody who might be right now on this day resilient as far as what we have to do about COVID-19, I don't know what they're going to be like in 2 months or 3 months, or if we open the schools and have to close them again. I think we could see a very serious uptick in mental health issues. And I think one of the things that's important, Jonathan, for your profession is to be preemptive about all this and start putting out information, however you need to do that, to have people anticipate that resiliency is not a binary situation. You either have it or don't have it. You may have it, it may wane, it may end, it may disappear. But the more that could be done in this sort of preemptive frame of mind, in addition to being able to help people through the crisis, I think would be the things that I'd be thinking about.
I want to ask, since you think at a large scale, I want to ask a question that pertains to global or national efforts, because of course we're doing things in our own health system and community, but this is something that is a pandemic and also reverberates back to us. So When I was in medical school, infectious disease was thought to be a very uninteresting discipline because of vaccines and antibiotics. And then came AIDS, and then came swine flu, and then came SARS, and then came Ebola, and then came Zika, and now we've got this. But all of these pathogens, which largely were new to human species, came from either Africa or Central Asia, Central China, and in times past, they would have been isolated because there wasn't the ability to be transported by a vector, human vector, and test the human. So where's the WHO? Where's the World Bank? Where's the UN? I mean,
yeah. So this is a very important question, Jeff. I think, well, first of all, just remember the Spanish flu of 1918 killed probably 50 million people worldwide and about 700,000 people in the US when we had a much, much smaller population. So things still managed to spread. And we had all sorts of other things that over history have been devastating in Europe and so on. The problem is that, or one of the things that we've been, I guess, taught the hard way is that these kinds of major health problems that are in the infectious disease category, by the way, I still wouldn't go into infectious disease myself, but one of the things is that we cannot do this as individual countries. This compels us to think globally. The World Health Organization has its warts and flaws, but it's the only organization that has participation of all countries and has some level of impact in all countries. One of the things I hope for the World Health Organization is that I would like to see the likes of Zuckerberg and Gates and others, other phenomenally wealthy people around the country, to independently set up an endowment for the World Health Organization so they're not dependent on national contributions. It wouldn't take all that much, $30-40 billion, which would be easily available through a handful of very wealthy individuals, so that there was total independence from a financial point of view, so the World Health Organization could do its thing. And like I said, they've made their mistakes, but they're basically all we have. And really, it's not the World Bank. The World Health Organization obviously is part of the UN as well, but we need a very strong, very influential entity like World Health Organization to help identify, deal with, prevent things like the COVID-19 from becoming a pandemic, or if it does, we need global strategies to help contain it. And by the way, this fact that we're being taught a very hard lesson in the necessity for international cooperation and collaboration, I'm hoping will spill over to other things like solving the climate crisis or protection of the environment or biodiversity and whatever. I think if we're lucky, there will be a spillover understanding of how much we really do need to have that international coordination. But I am a fan of, even though I've been critical in the media of them, there's been some recent incidences, but of sort of mistakes and miscommunications and whatever. But we need them. We need them independently funded, maybe at a higher level than they currently are. But I think hopefully that someone answered your question. But I'm a big believer.
What country do you think has done the best job?
New Zealand.
Mm-hmm.
Germany's done a pretty good job. There's Taiwan has done a good job. Now, when we're saying a good job, we mean that the cases either never really got to a very high level, or they got to some peak and then really tapered down. And New Zealand's a good example of that. But be sure that none of the countries that has more or less gotten control of, or quote unquote conquered COVID-19 can rest comfortably thinking that they're done with it, because once we start having more international travel, there are still many people who are vulnerable in all the countries that have been successful. So second waves in those countries are entirely possible. So that brings up the question is how long do we sustain, let's say, travel bans or other ways of more draconian ways of controlling spread within a country remains an open question.
Jonathan, last question.
Yeah, so this is, I realize this may be,
Last question before we open it up. I mean,
yeah, I realize this may be a tough question to answer, but one of the things that's particularly concerning about the schools is it's not just the loss of the academic learning for kids, but schools obviously provide social interaction, social development, learning from other children, navigating playground politics. And even in the a situation where we have optimal online learning, all of that is still lost. I was wondering if you could comment on.
I can, and I'm going to comment on it personally. I think it's a really good. I'm so glad you brought that up. I'm asked about that. So our 4-year-old, adorable youngest grandchild, who had been in a preschool program until this all happened, so much needs to have that the social interaction in a classroom. I can't begin to tell you. And I think that's true, obviously with older children as well. And no one ever really talks about that enough. And I think you should write an op-ed about that, because it's really very important that it's not just are they learning to read and develop those academic skills, but are they in fact getting the social interactions that are so important to child development. And many are not, and many really need it, including Oren.
Yeah, and I suspect it plays a role in their resiliency, also having those social interactions.
Absolutely. Yeah, absolutely.
Well, as we try and think about, the future and what is the future workplace and patterns of service provision, it's a question about that sort of how critical, if you're doing all telemedicine and you're not in a central clinic, hospital, office, whatever, with your colleagues who you're bumping into the hall and chatting with, what is lost there, or what is in terms of the lack of the socialization or the synergistic interactions that can come out of the congregant staffing of healthcare.
Also, very good point, Jeff. I don't know what the consequences will be, but there's obviously a big move to telemedicine, but also telehealth, but also just the meetings like this. Because if we were in normal times, before and after the formal presentation, we'd be hanging around, we'd be talking to each other, people would come over, we'd have chats, and ideas will come up that may not come up in the Q&A. And we're losing that, because we're going to finish this and then we're going to shut down this web event, and that's it, and go on to the next WebEx or Zoom or whatever it might be. And I think we're losing something, and that has not been defined yet. On the other hand, when we're asking people to kind of start coming back to work, if you work in a building, you're a lawyer, you're an insurance company, whatever it is, you're in academic medicine and not seeing patients, and you don't need to go on the subways and buses. If you don't need to, and you could do your meetings like this, that's probably safer from a public health point of view, but we're also missing a lot of the hard to define value of being together in one place. And I don't think we totally understand that yet, but I'm positive there'll be things written about all that as well.
Well, people are social animals, and there's a reason for that. Cities exist because people want to be and so we're really in uncharted territory. Okay, well, I'm going to, with Jonathan's assistance, feed you some questions that have come in from the listening audience, which at its zenith was, I think, 260. Simon, one of our PGY4s, said, given the positivity rates during the New York dominated wave, do you suspect the previous peak was actually larger?
It was larger, and it started earlier than we know. The lack of having appropriate amounts of testing available early on has really hurt us and continues to hurt us. But yes, and I think, one of the commentators recently said that there's probably not, 22,700,000, it's probably 20 million cases. The earliest predictions when we first started dealing with this, which I believe, is that between 50 and 65% of the population will be infected. The vast majority will be asymptomatic or mildly symptomatic, and a very small minority will have to go to the hospital or into an ICU and not make it. But ultimately, we're going to have 150 million or more people who have been infected with the SARS-CoV-2 virus.
I heard Scott Gottlieb this morning say that he believed that for every case that is identified, he believes that there's really 15 that haven't been. So there's a huge number of, there's a huge underestimation of the actual figures.
Absolutely, I totally agree.
Another question from the audience is, I have a number of patients who tested positive for COVID at the time of the illness, but are now antibody negative. How should we interpret the meaning of this?
Well, first of all, where they've been tested, the tests that are out there commercially are extraordinarily inaccurate. The Abbott test that was promoted by the president and some of the other technologies have a 50% reliability in terms of sensitivity and specificity. That means lots and lots of false negatives and false positives. So it's hard to know whether those patients were tested in a reliable lab, which by and large means a specific university lab that's been working on this as opposed to a commercial lab. So it's hard to know how to interpret that. They may or may not be susceptible to another infection. They may or may not be spreaders. We just don't know what to say about that. But in a question like that, I would repeat the test and try to get it done up at the Columbia or Mount Sinai or one of the other labs that's really good at this.
Let me just add that so I participated in a forum with Scott Gottlieb and Mark McClellan and Rob Califf and some of the people who are heads of the various companies that are trying to develop treatments or testing devices. And their current thinking is serologic testing for antibodies is not really clinically informative at the individual level. So, it may be a rough indicator of who had it, but it's not anything that informs anything in terms of immunity or in terms of, so the RT-PCR antigen test is really the key thing. And its positivity is time limited.
Yeah. But Jeff, I would say that, Mount Sinai has tested about 20 or 25,000 people for antibodies. Those that have tested positive in their lab, there's been 0 new cases of COVID-19 among those. I don't know what that, there's obviously needs to be much more testing over longer periods of time, but that is meaningful because if in fact good, accurate, appropriately sensitive and specific testing for antibodies, that's where I sent my barber to get tested. And the fact that he had a high level of antibodies made me feel pretty confident that in fact he had immunity and was not going to be actively carrying the virus. If he had just walked off the street into one of those CityMD type of urgent care centers, I wouldn't feel confident at all. And so this is a problem with technologies. Don't forget, the FDA is testing between the PCR tests and serology tests. They're looking at, I don't know, probably close to 500 different technologies. And the ones that are out there have mostly not been thoroughly tested by the FDA, but they're given what's called EUA authorization, which is emergency use authorization, that it's not been fully examined, but here you go, good luck. So the variability in quality and accuracy of the test is extreme.
I agree, and I invite you back next week when Eldad Hode, who's in the pathology department, is here. But just to respond briefly, so you've got serologically measurement through ELISAs of the IgM and IgG bands.
Yeah.
And then you have a report that's usually categorical, positive or negative. What's the threshold of that? How long do the antibodies last? Are they neutralizing antibodies? So you're citing the large number of samples that Mount Sinai has and their observational impression that nobody's gotten infected, and the inference that it provided some level of immunity is very valid, but it's not anything that really is definitive and can be sort of extrapolated to the assays that other places are doing.
Exactly right, Jeff. And I think all this is to say that we're in the very earliest stages of investigation of all of this, and which, by the way, I want to say this because I think this is important. Even when we've seen things in the peer-reviewed literature of the most respected journals in the world, medical journals, Lancet, New England Journal, where they've had to retract articles that are theoretically peer-reviewed but turn out to be not so much or not good enough, is testament to the fact that we have a lot more rigor that needs to be applied to everything. And you're exactly right. Those are observations from the Sinai group, not yet published and not yet peer-reviewed. I'm just, it's something that I'm aware of. But again, I think we need to be extremely careful about conclusions that are drawn too soon from even the most, prestigious scientists and labs that are working on this.
Well, yeah, except I would just say, so along with what they're doing at Mount Sinai, which, by the way, I'll point out is run by 2 psychiatrists.
You had to get the plug in. I understand. Yeah.
David Ho's been working day and night on this also. And where's the CDC? We're in this mess because the CDC totally dropped the ball on having a testing methodology when it was needed.
Yes. I mean, it's where's the CDC? I
guess that's a rhetorical question.
You're gonna force me to get back into politics, and I'm going to try to resist. But it was a major problem early on. The CDC, first of all, if you wanted an accurate test in the early days of this outbreak, you would send the sample to Atlanta, and the CDC would run it, and so on. Then they produced several hundred testing kits, which they distributed around the country, and it turned out they were deeply flawed. The reagent materials and so on were fragile, and whatever happened. So they pulled them back, and this problem was never really fixed. And I don't know where the CDC is. Why isn't the head of the CDC the front person? This is Dr. Redfield, in talking about what's happening and giving the daily briefings. And Fauci's great, so Fauci and the head of the CDC should be the people that are out front talking about where we are, what's going on, making sure the testing that they were producing at the CDC was effective. They have all been sued by a White House that there really is not all that interested in evidence or science, or doesn't trust them, or whatever the pathology is that exists at that level. And that would be in your field. But all I can say is I don't know either. No one knows. And by the way, I've spoken to Tom Frieden, the former administrator for the CDC, who said that in spite of talk, there was never really any substantive cutbacks in the CDC's budget that materialized. And the people that are there right now, except for Redfield and his immediate staff, were the same people that worked for him when he was head of the CDC during the Obama administration. So there will be books, there will be articles, there will be after-action reports and postmortems written about every aspect of this. But one of the more fascinating things that we'll look forward to is what exactly happened, to respond to your question, in the CDC's gross failures to produce what we needed at the right time.
Jonathan, why don't you go through, because there's a bunch of questions that are piling up, and I'll be still.
Okay. So one question that came up, I'd love to get your thoughts on also is, we are thinking through how to best resume clinical research and how to minimize risk, and would love to get your thoughts on that.
Yeah. You mean, you're talking about research that requires somebody to be in a lab or in
Yeah,
a,
it requires someone on site and isn't
yeah,
necessarily of direct benefit to the participant.
right. So I'm sure you're aware throughout the Columbia campus and especially the Earth Institute where my center is located and Lamont Donnery uh, campus, a lot of people need to be in labs. That's different than say my center, which we could just go on with WebEx, Zoom type meetings, for a long time. There are people and graduate students whose careers are dependent on continuing their NIH or whatever funded research. And it's a major problem. So there are committees at Columbia that are working on this and guidelines, and partially, some of them are already out, some are not. And I don't think they've been thought through sufficiently, frankly. And I don't know. It's sort of, you're going to look at the guidelines from the state. You're going to look at the guidelines that come out of Columbia University, and maybe from New York, in your case, New York State as well. And they're going to try to come up with policies that are specific to your programs. But it's not easy because are you going to bring people back, and are they going to be taking public transportation? Are they taking subways and buses? How are they getting to work? What are the safeguards at the workplace? What are the rules? How many people are allowed in the lab, any lab at one given time? These are issues that will have to have answers, even though we may not have evidence to support these specific answers. My oldest grandson, I keep referring to my grandchildren, but it's my frame of reference these days, but my oldest grandson is a junior at Ohio State. And I've been in consultation with the president there for some time about this, but their rule is they're going back to campus, but they can't be in classrooms that have 100 or more people in them. Those people are in those large classes will have to work remotely. So I said to my grandson and to the president, where'd you come up with 100? Why not 50 or 92 or 200? And there's no answer. And at some point, get comfortable with that uncertainty and make arbitrary decisions, and that's all we got.
Listen, we have a long list of questions, so I'm going to ask Jonathan to go through this with you. But Irwin, as much as I'd like to hear, as much as you have to say about it, let's speed date on these.
Lightning
round. Yeah.
Lightning round. Okay, go ahead.
Could you please speak to the responsibility for future health literacy of the American public, especially in its ability to digest scientific information and make decisions accordingly?
Critically important agenda, and that's going to happen through the media. There's just no way around that. And it's going to be the media as the intermediary between the scientists and the public.
Somebody has to call the media to task. The fourth estate is falling down. They're benefiting from the ratings of the Trump presidency and the crises, but they're not necessarily fulfilling that aspect of what their responsibility might be. No response needed.
Next question. Do you know how other countries, for example, the UK, are moving forward with opening schools? Are there any lessons that we could be learning?
I don't know how the UK and other countries are handling the school opening thing specifically. Sorry.
Okay. Let's see. How long after you were exposed to COVID and before you show symptoms do the test turn positive? Essentially, how long does it take for the test to turn positive?
3 to 5 days.
Right. Let's see.
There was a related question to that said, what if you have a positive RT-PCR, but you have negative antibodies? Does that mean you didn't have the infection?
In other words, if you had it, let's say you got the PCR 3 weeks ago and you were positive and now the antibodies are negative, is that the question?
Yes.
Like I said before, there's so much inaccuracy in the testing, it's hard to know what to make. But if you had symptoms consistent with COVID-19 and you were positive, then you're positive. And most people will develop some level of antibodies. But again, we have too much uncertainty with sensitivity and specificity of the testing.
So here is a a fairly grim question. You mentioned the end of 2021 as the date where perhaps we could be on the other side of the pandemic. Is that overly optimistic? It presumes an effective vaccine and that people will take it.
It's optimistic, overly optimistic. I don't know how to evaluate that, but let's just say that before that moment, it's very unlikely that we'll be back to something that we recognize as completely normal, which we may never get to.
Irwin, what are the chances of politicization of the vaccine distribution? So, if Sanofi is the first across the finish line, or AstraZeneca, as opposed to Moderna, will countries, will rich people get it? Will healthcare providers, will they use it to get their economies back in order and get an economic advantage, or will it be done in a humanitarian way?
It'll be the former, like it always is, unless there's a serious demand from political leaders and the public that not happen. But we'll definitely have to keep an eye on that. I do worry about that, and we'll just have to see. But hopefully that will become much more democratized than you're implying in the first part of the question.
Well, I mean, when there is a vaccine, ideally they'll have to produce how many billion doses?
7+ billion.
And then how do you distribute it?
Well, there's places where you can't get any health care to begin with. And so you have to layer upon terrible or non-existent health, quote unquote, systems. And that's going to be a problem, not only globally, but in the United States as well. We have 65 million Americans who live in what the federal government calls health professional shortage areas, which is very insufficient numbers of physicians and other health professionals in a given geographic area. So we're going to have major problems with distribution and actual administration of the vaccine under the best of circumstances.
I think this may be our last question, which is what is the current understanding of CNS effects of the virus?
Yeah, so we're just beginning to see people coming up with all kinds of symptoms, from persistent confusion to more permanent loss of smell and taste, to other neurologic symptoms, and by the way, including stroke, that we'll have to be tracking. And there's going to be a lot of, I think, studies designed to make sure we understand the full range of the impact from central nervous and peripheral nervous system point of view, in fact.
Jonathan, I found one question that I think we should ask him before we end, to put Irwin on the spot a little bit. So if you were the governor or the mayor, would you reopen, or when would you reopen?
Reopen schools or business?
The phase 1 reopening, which is the
Yeah.
construction can resume, you can serve restaurants outside, you can go to the door of stores and they can bring things to you, so forth.
Well, it depends. Retail stores can be handled. In other words, we can have people waiting on lines. We could reduce the number of people in the grocery store and the pharmacy. We can put up the plexiglass barriers. We can require social distancing in the stores and require face masks. And I think there should be teeth behind that, because it's really kind of optional whether, even though it's been asked or it's a guideline from the state, a lot of people are ignoring that. And I think people should have the authority to call the police and remove people from stores if they're not complying with masks, let's say. So those kinds of things we can deal with. However, things like opening bars, gyms, and even restaurants, I think we need to be very, very careful about. And I think we open way too early. And that's part of the reason that we're generating these new surges in the South and across the Sun Belt.
Well, your op-ed that we distributed from the Post in May on generational effects of COVID on children, as I mentioned to you, is right, dovetails with the intergenerational psychiatry center that Jonathan and Christiane Duarte are leading. So I hope that through their efforts, we can draw you into that, since you've been doing this for a longer time than you'd care to admit, and date yourself in the process. But we really appreciate you taking the time to be with us, Irwin, and all the good work that you've done, and look forward to continuing more and more interaction in the future.
I'd love to, Jeff, and thank you for having me. And I would be interested in the follow-up that you talked about. So look forward to more.
Sounds good.
Wonderful.
Jonathan, anything further you want to add?
No, I guess I just wanted to say that it is tremendously helpful to hear from you, Dr. Redlener, and that giving answers that are clear and covering such a wide range of topics, and also direct without sort of sugarcoating or obfuscating in any way. So thank you so much for your time.
Happy to be with you, Jonathan.
Well, that concludes this grand rounds, and we'll see you next week. And in the meantime, be well and stay safe.